Hello, everyone. My name is Sydney Bowmaster, and I'm a third-year internal medicine resident at the University of Iowa. The title of my talk today is called Improving Utilization of SGLT2 Inhibitor Therapy at a Local VA. Here are the objectives of my talk for today. First, we'll review SGLT2 inhibitors and the recent literature behind them. Next, we'll introduce our quality improvement project, explain our methods, and discuss our data. Lastly, we'll reflect on our project's strengths, limitations, and next steps. SGLT2 inhibitors are the gliflozin drugs, which act by preventing renal reabsorption of glucose, leading to increased urinary glucose excretion. Overall, this class of medications has received a lot of attention in recent literature. Empagliflozin is the SGLT2 inhibitor on formulary at the Iowa City VA and will be a focus of our talk today. This figure from the Cardiovascular Diabetology Journal illustrates results of the Empagliflozin trial, which studied the effect of empagliflozin versus placebo in adults with type 2 diabetes. In this study, there were significantly lower rates of death from cardiovascular causes, hospitalizations for heart failure, and death from any cause in the empagliflozin group. Several other studies listed here have shown similar promising results, which suggests that this is a potential benefit of the drug class as a whole. So if you consider the promising literature favoring the gliflozin drugs in combination with the prevalence of diabetes and cardiovascular disease in our country, the magnitude of potential clinical impact is quite intriguing. So this ultimately inspired ideas for a quality improvement project in our primary care clinics, where we felt there was room to increase SGLT2 inhibitor utilization for these patients. Because this literature is so recent, we suspected there to be a notable gap between patients who were candidates for gliflozin drugs and those who were actually prescribed one of these medications. Here's a few details about the project itself. It took place within the Internal Medicine Resident Continuity of Care Clinic at the Iowa City VA. Participants included 11 internal medicine residents, 2 VA pharmacists, and 2 faculty mentors. The project was deemed HSRD exempt. As I mentioned earlier, empagliflozin is the SGLT2 inhibitor on formulary at the VA. Inclusion criteria per VA pharmacy guidelines include a history of cardiovascular disease and/or CKD. For the purpose of this project, we'll focus on patients with a history of cardiovascular disease rather than CKD. Patients also must have a history of type 2 diabetes and be receiving metformin or another agent if unable to use metformin, which means empagliflozin shouldn't be a patient's first-line diabetic agent. Apart from drug hypersensitivity, exclusion criteria for empagliflozin included an A1C over 10, at which point insulin therapy should be adjusted. Pregnancy, a history of ESRD requiring dialysis, frequent UTIs, or risk factors for UTI are also among the VA exclusion criteria. Prescribing is also not recommended in patients with a history of pancreatic disorders, suggesting insulin deficiency, since this may predispose to the development of euglycemic DKA. This slide here summarizes our baseline data as well as our stepwise approach toward identifying patients who are candidates for intervention. Each resident provider reviewed his or her own panel. Of the 511 total patient charts that were reviewed, 53 or 10.4% met inclusion criteria for prescribing empagliflozin. 9 of these 53 patients met exclusion criteria. So of the remaining 44 eligible patients, 1 patient or 2.3% already had empagliflozin on their medication list prior to our intervention period. So as we suspected, there was definite room for improvement in SGLT2 utilization for our clinic patients. The baseline mean A1C and BMI in this group are shown here. The overall aim for our project was to increase utilization of empagliflozin for eligible patients to at least 30% over a 6-month period. Our outcome measure was SGLT2 inhibitor utilization. Our process measures consisted of patient communication and lab monitoring. Balancing measures listed here included deprescribing after an initial trial on empagliflozin, as well as known or anticipated side effects of SGLT2 inhibitors. In order to go about prescribing empagliflozin, we had several options for discussing the desired intervention with each patient. Ideally, we would see patients face-to-face in clinic, where a more thorough patient encounter could occur, including discussion with pharmacy and updated baseline labs. Alternative options included a letter or telephone conversation, which we had to utilize more than initially expected due to COVID-19. If patients were contacted by phone or letter, a script was used to facilitate standardized communication, which included some basic information regarding SGLT2 inhibitors. A decision was ultimately made following a personalized discussion between the patient and his or her provider. So at the end of the 6-month intervention period, 13 of 44 eligible patients were prescribed empagliflozin, so we met our target of 30%. An additional 5 patients had been trialed on empagliflozin, but the medication was later deprescribed either due to an adverse reaction or patient noncompliance. In 16 cases, or 36%, empagliflozin was not prescribed per provider preference due to A1C already at goal. 6 patients had no appointment or recent labs documented. And of the remaining 4, comprising the other category, empagliflozin was not prescribed for reasons such as a history of brittle diabetes or a history of lower urinary tract symptoms that were anticipated to be exacerbated by empagliflozin. Analysis of pre- and post-intervention data via the McNemar's chi-square test revealed a statistically significant increase in the SGLT2 inhibitors prescribed across our 6-month intervention period, with a test statistic of 10.1 and a p-value of 0.0015. We were also interested in any effect on A1C and BMI in these patients. This slide shows pre- and post-intervention data according to whether patients were or weren't taking an SGLT2 inhibitor at the end of the 6-month period. Interestingly, mean A1C increased slightly in both groups, while mean BMI decreased in both groups. Statistical analysis showed that there was no significant difference in the change in A1C or BMI between the SGLT2 inhibitor or the no SGLT2 inhibitor groups. P-values for each of those analyses are shown here. Regarding our balancing measures, 2 patients who were prescribed empagliflozin later developed an AKI, and another 2 patients developed polyuria, leading to deprescribing. Both patients who developed AKIs were noted to be on concomitant diuretic therapy. There were no infectious complications, hypoglycemic events, or TKA episodes seen in either group, and no CHF hospitalizations occurred. Here's a table summarizing the strengths and limitations of our project. The interprofessional teamwork helped streamline the process of SGLT2 prescribing and optimize patient communication. Thanks to pharmacy participation, we obtained clear inclusion and exclusion criteria specific to the VA guidelines. The high feasibility and standardized communication methods also contribute to the strength of this project. The fact that this was a single center study poses limitations regarding the number of patients included and the generalizability of our data. Additionally, some veterans have local primary care providers in addition to their care at the VA, which can contribute to incomplete patient records and hesitancy to prescribe empagliflozin if the patient's diabetes is primarily managed and monitored by their local provider. A low baseline A1C limited the degree of intervention that was accomplished. And finally, the variability in the duration with which some of these patients were taking empagliflozin raises the question as to whether our data underestimates the potential clinical benefits if patients weren't on the medication long enough to see these favorable outcomes. Overall, our QI project served as an effective method for increasing SGLT2 inhibitor utilization. Given our observations of AKI in patients on diuretic therapy, we'd recommend increased caution prescribing SGLT2 inhibitors in this population. Focusing on our own patient panels allowed for closer monitoring for adverse outcomes and can help inform larger data pools for future PDSA cycles. Finally, we were able to experience firsthand the value of an interprofessional team. Collaboration with pharmacy especially helped ensure safe and effective prescribing in this academic outpatient setting. Looking forward, our team plans to continue to follow up on patient-level outcomes, specifically A1C and BMI, as patients remain on empagliflozin for a longer duration of time. We will also continue to monitor for any adverse outcomes potentially associated with SGLT2 inhibitors. Future PDSA cycles will likely involve expanding our project to additional VA resident clinics, as well as potential collaboration with nephrology to target patients with CKD with or without established cardiovascular disease. Here are my references. Thank you for listening. I'll take any questions at this time.